If you get into an accident and you're rushed to the hospital, what actually happens to you? Most people have no idea. They think it's chaos, but in reality, it's a very structured system. Before you even arrive, we get a pre-alert phone call.
Code red to A&E resus, or code red to A&E resus, code red to A&E resus.
We're told the patient is coming in, what kind of accident it was, and what injuries we might expect. By the time you arrive, a full trauma team is ready. This usually includes the emergency department consultants and team, the trauma and orthopedic surgeons, the general surgeons, and depending on how severe the case is, you can have anesthesia and theatre staff. They may also come down. The first thing we do is something called the primary survey, which follows a strict ATLS structure. ATLS is Advanced Trauma Life Support. And we look at your airway, breathing, your circulation, disability, and exposure. The goal is simple. We find anything that might kill you and fix it immediately. We're looking for things like an airway that's blocked, a collapsed lung, severe bleeding, brain injury, or anything causing shock, because these are the injuries that can take a life within minutes. Once you're stable, you go for a CT scan, usually from head to pelvis. We're looking for hidden injuries like any bleeding, any fractures, and internal damage. Then comes the secondary survey, which is a full head-to-toe assessment. This is where we make sure we haven't missed anything and where we start to identify injuries that might not kill you immediately, but could threaten your limbs or affect your long-term function. If you have fractures, they're carefully assessed, we x-ray them, we reduce them, which means that we realign your bones and we stabilize them. This is because fractures aren't always simple. Sometimes they can damage your nerves or blood vessels, and in many cases, they can threaten the limb itself. Then we have to make a key decision. Do you need surgery? If you do, you have to go through something called the consent. Basically, if you're awake, the surgeon will talk to you, explain the operation they're planning to do, the risks of the operations and the benefits, and if there are any alternative ways in which we can manage you without an operation. If you're unconscious and the surgery is needed to save your life or your limb, we just proceed under emergency consent. If your surgery isn't immediate, you're admitted and your operation is planned. You'll be kept nil by mouth, which means you can't have any food or any drink before your operation. Patients are usually kept nil by mouth from 2 a.m. onwards, because during general anesthesia, your body loses its protective reflexes. Even something as small as water or even chewing gum can increase the risk of aspiration, where your stomach contents can enter the lungs, which can be life-threatening. The next morning after your accident, your case is discussed in the meeting. We review everything, the mechanism of injury, the confirmed injury, and the operation we're planning to do. And most importantly, how do we fix it? And what's the safest time to do it? Before the surgery, there is a team brief, which includes having the surgeon, the anesthetic team, the scrub nurse, and the operating department practitioner, known as the ODP. We go through the plan, your case, the equipment, and any potential complications that need to be discussed beforehand. You're then taken to the anesthetic room. You're put to sleep safely and carefully. And after that, you're moved into theatre, and we position you depending on the type of surgery you're having, which could be on your back, this is called supine position, on your front, which is a prone position, on your side, a lateral position, or sometimes you can have a modified position like a lazy lateral. Then your operation happens. Once it's done, you're brought out of anesthesia and you're woken up. You then go to recovery, where you're closely monitored until it's safe. After that, you're transferred to the ward. In the ward, you're being monitored. We aim to control your pain and start your rehabilitation. Your surgeon will usually come and see you, and in most cases, it's likely when you're still groggy. So many patients don't really remember when I go see them post-operation. So we check again later and explain everything properly. We tell you how the operation went and if any complications occurred. Once you're safe, you're discharged home. And you come back to clinic a few days after. Usually it's 10 days after the operation, We check on the wounds, we review the scans, and plan the recovery period. So, what looks like a single event, an operation, is actually a long structured journey, from the moment you arrive to long after you leave and finish your rehabilitation.